we had the first case of COVID positive patient on the 8th of March, and we were all expecting that it's going to hit us. But the first case started, and in the first week or two, it was trickling like 2 or 3 patients every day. But then very soon the numbers started to increase quite significantly. And towards end of March, we had pretty much most patients who were coming into hospital were COVID patients, and all non-COVID patients had stopped coming to the hospital. And as a nephrologist, we also have to change some of the ways we work. Particularly, we have a significant number of dialysis patients who has to visit the hospital or a dialysis center, irrespective of what the pandemic situation is. So our workforce, we have to make a lot of changes. And by end of March, we completely changed the teams. And it's extremely important. I want to stress to people that this is a pandemic. It is an unprecedented situation. And we have to work as a team, not just within the nephrology team, but with all the medical consultants in the hospital has to work as a team to get through these difficult times. So at the peak of the pandemic, which we have reached now, but I'm sure some countries are still heading towards the peak. What I would like to say is, the number of admissions will increase, and a lot of patients will present with typical symptoms of COVID, like cough, fever, feeling fatigue, very tired, muscle aches. But sometimes, one thing I would like to add is we have to be very careful. In the middle of all this, we might also get a non-COVID patient with cough is not the symptom of only COVID. It could be sometimes because of a cardiac failure or a respiratory infection other than COVID can also be possibility. And particularly in nephrology patients, dialysis patients, or a transplant patients who are all extremely vulnerable, who has a lot of comorbidities along with renal failure, we can still expect the same symptoms, but sometimes we might be caught up with non-specific symptoms. It might be just not feeling well, where it might not be a specific symptom, or the temperature might not be that high, and feeling unwell is also a suspicion. We should raise that whether it is a possible COVID, and we have to keep COVID in the back of the mind all the time, and that's how we work. And when the numbers increased at the peak, then all medical wards had pretty much become COVID wards, and our work schedule, we divided the whole nephrology team of 10 consultants into 2 different teams. And to reduce the exposure to the COVID patients, what we did is, how do we do that? You have to still look after the patients, but at the same time, we have to look after ourselves so that we can be there for the patients when they are their need. So we divided into two teams, and instead of working like continuously, we said 3 days on the ward and 3 days off the ward. So you don't go to the hospital on the 3 days. Even at the extreme times, we might go to the office to do some work, but we all had given laptops at home, and we used to do a lot of work from home, like calling patients and doing clinics all from home. But 3 days when we were in hospital, we used to see a lot of COVID exposure in those 3 days. And that sort of helped to get a bit of balance between working in the hospital and out of hospital, and reduce the exposure to COVID did happen. And another change was renal workforce. The junior doctors in renal was not sufficient enough. So what the hospital did a brilliant job. I think most hospitals did this. They pulled all the junior doctors, like registrars and foundation doctors, the trainee doctors, essentially, to a team, a bigger pool, and divided them into all the COVID wards. And in fact, one of the good things which came out was the hospital was very well staffed. All the wards had enough doctors, both in the day and in the night. For us, the change was we might go to the ward and then see a completely different specialty doctor. It might be an ophthalmology registrar who would never worked in medical wards. It could be an orthopedic registrar or a surgical registrar trainee in a medical ward. And I know in some hospitals in the country, there were other specialist consultants like surgeons and dermatologists, rheumatologists did go into the medical ward and work in their capacity. I mean, you won't be working as a COVID specialist consultant, but you will be doing a lot of the jobs which any doctor can do. So that's how we divided the work and got through this difficult period. And now, as the numbers have decreased, and at the peak, we stopped all sorts of outpatient work and patients coming into the hospital, like even our own kidney patients, we didn't bring them to hospital, or even we didn't contact them for a short period of time. But as soon as the peak ended, we because the 3 days we were working from home, we thought like we will do some virtual clinics wherein we've got a list of patients who we have to look after and then call them on the phone and talk to them, do the consultations over the phone. And one thing for as a nephrologist is we need to have a blood test to know what their kidney function is to have any sort of discussion. So they used to go to the nearest surgery, primary care, to get a blood test done, or if sometimes even the hospital opened the blood test facility for these patients throughout the time, so they can come in. But instead of like all coming in at one time, they need to phone and have a specific time so that they won't be like crowding in the blood test department. So that's how we managed and got their blood test done and did the virtual consultations and effectively looked after our patients reasonably well in these difficult times.